vitreoretinal surgeon, Dr. Apoorva AG. So Dr. Apoorva will be speaking on why there will be a cystoid macular edema post-cataract surgery and how do you manage it. Over to Dr. Apoorva,
Thank
please.
you, sir, for the opportunity. Modern day cataract surgery is quick, safe, precise, and has perfect refractive outcomes, and the patient expects them too. PCME, like we'll be calling pseudophakic cystoid macular edema from now on, is still the most common cause of low vision post cataract surgery. It ruins our perfect 6-6 N6 outcome. We all know how it can be frustrating. CME has long term effects, and chronic CME can be potentially untreatable. So, even in an uneventful phacoemulsification, clinical CME can be present in 0.1% to as high as 2.35%, and OCT evidence after phacoemulsification is also a little higher than this. This is clinical CME. Risk factors include age, atherosclerotic disease, younger patients, younger than 55 years of age, ocular conditions like diabetic retinopathy, vein occlusion, uveitis, using PG analogs for antiglaucoma medication, a previous diagnosis of epiretinal membrane, like in this case, who developed CME later, and a history of RD repair. So preoperative risk factor, this is an example, like I was saying, a thin ERM was present preoperatively and this patient ended up developing a PCME. Let's look at this example of a 60-year-old lady. She's a physician and she's had multiple anti-VEGF injections in the right eye for supposed recalcitrant, diabetic macular edema, and the left eye is under observation on OCT. So when we do this FFA, the left eye looks okay, but the right eye shows this petaloid leakage in the in the macula, and she had peripheral capillaritis also, which was undiagnosed clinically for a long time, and this patient ended up receiving Ozurdex after a diagnosis of a probable exacerbation post pseudophakia. So the surgical associated risk factors for PCME include, of course, a complicated cataract surgery. We all know this, that tissue trauma during the surgery, a posterior capsule rupture with vitreous loss, traction, long surgical duration, IOL dislocation, and even an early YAC cap post-operatively are all risk factors for pseudophakic CME. So we know the pathogenesis since our first year of residency, surgical trauma to the intraocular tissues. It could be during the surgery or post-operatively because of the haptic rubbing the iris, wit in the AC, iridocorneal adhesions, causes release of PGs and other inflammatory mediators, and then it increases the permeability of perifoveal capillaries, disrupts the outer blood retinal barrier to be specific, which is why in pseudophakics, there is cystic accumulation of not only intraretinal fluid in the OPL and between the OPL and the INL, but also subretinal fluid. Like you can see in this example showing the difference between a diabetic macular edema with hard exudates and cystic spaces, with the inner blood retina barrier being affected, and a pseudophakic CME where there is a predominant SRF because of the outer blood retina barrier affecting. So I'll just skip this slide and we'll go more clinical. There is, the patient presents with low vision for near and metamorphopsia, but like we all know, the biggest overarching symptom is dissatisfaction, especially it pinches when it's post a premium IOL. So whenever a patient is referred as dull FR by our anterior segment colleagues, it's very important to check for the macular status, no doubt, but a thorough anterior segment examination is crucial. You can see evidence of complicated cataract surgery, maybe in the form of PCR. There'll be, of course, a dull FR and cystic spaces. OCT is the diagnostic modality of choice. FFA can be done rarely in cases where the diagnosis is uncertain. So the treatment includes topical NSAIDs, very popularly used. Oral carbonic anhydrase inhibitors have been known to be effective according to some French studies. Posterior subtenon triamcinolone, intravitreal steroid injections, either IVTA or a DEX implant, and surgery in the form of anterior vitrectomy and pars plana vitrectomy. Topical agents include nepafenac, bromfenac, endomethacin, ketorolac, and interferon is supposed to also work as a novel treatment, which is even economical in fact, because it downregulates not only VEGF but also some other cytokines. Next is periocular steroids in the form of subtenon injection of TA. It is effective for pseudophakic CME. Of course, you have to also relieve the inciting factor here, in this case vitrecinaceae, iridocorneal adhesions. This particular patient did well with an anterior vitrectomy, release of adhesions, and a posterior subtenon TA. So like I showed in the previous slide, it's very important to set the offending factor right. It's not enough to just keep injecting with PST, but also relieve this chronic rubbing of the haptic to the iris tissue. We do an anterior vitrectomy and reposition the haptic into the bag if possible, or at least safely in the sulcus, ensuring there is no rubbing. So then intravitreal steroids, let's look at them. This is an example of the efficacy of a DEX implant, a 63-year-old man who had undergone very uneventful phacoemulsification 3 months prior, and there was absolutely no change with the posterior subtenon. Received his first injection of Ozurdex, however, there was a rebound at 3 months. This is post the second Ozurdex, and then there was a rebound after 3 months of the effect getting over, and then at 1 year after the third Ozurdex, this patient is somehow probably had 3 Ozurdex injections in his destiny. He is holding on very well post 1 year. Some of my last slides, dexamethasone has been shown to have very good effects on recalcitrant macular edema due to Irwin gas, and a laser vitreolysis can be considered in a singular vitreous strand, like in this case. Definitely a YAG vitreolysis is a non-invasive procedure that can be tried. Well, when there is PCME with an ERM or a concomitant VMT, vitrectomy can reduce the concentration of inflammatory mediators and growth factors, and anterior vitrectomy with a pars plana vitrectomy can reduce the load of those factors. Now let's look at this patient. She has been having low vision post-cataract surgery for a very long time, probably more than 6 months. She comes to us and very surprising that she had worsening with PST. Now you can see we gave actually Eylea, which is longer acting, but it kept worsening. What I want to say is this kind of degenerative edema with bridging processes, nothing really works. Anti-VEGFs have been seen to be effective, but there's no significant difference between the anti-VEGF agents. We know that prevention is key. Preoperative NSAIDs may help, especially with Nepafenac, either Nepafenac or Bromfenac or Ketorolac. All of them have pretty similar efficacy. NSAID alone or in combination with steroids is better than steroid alone. Prevention is key. I'll say that again. Preoperatively, check thoroughly for DR, subtle signs of vein occlusion, uveitis, thin epiretinal membranes. Rule out PG analogs if they are being used for glaucoma. Treat these conditions preoperatively. There's definite role of topical NSAIDs perioperatively. Surgical factors, ensuring optimal pupillary dilatation, limiting iris manipulation, clean cataract surgery by limiting surgery-related factors. If there is a cluster of PCME, revisit the type of IOL, any change in the viscoelastics, any new variation employed in surgery, and if there is a PCR, handle it very astutely and with minimal collateral damage. I thank these people for their help. Thank you very much.
Thank you, Dr.